Railway Hospital, along with that various attachments at Bellevue Clinic, Fortis Hospital. So she's today going to speak on neck pain, which is we all know very important because nearly two-thirds of people at some stage they suffer from back pain, like for neck pain. For back, we know that each and everyone suffers in their lifetime, but two-thirds of people at some stage, mainly it is middle age, which suffer, who are the sufferers, and the chronic neck pain is found in 10% people. So it is not as common as low back, but then it is very common. And we frequently see these patients. So there are various causes, non-specific, specific. So she's going to highlight on that. And without wasting time, I think so. I hand over the stage to Dr. Krishna Poddar, who will be speaking on neck pain, its etiogenesis, pathogenesis, management, pathophysiology, and also the prognosis and future, how it has to be taken care of. Over to you, Dr. Krishna.
Thank you, Sunita, my dear friend, for presenting my CV. And thank you, IAPM. And good evening, everyone. So today we have the topic of neck pain. I find neck pain, like back pain, is not so easy. Sometimes it is very confusing. Patient come with some shoulder pain, and they will say and they will tell you, I am having spondylosis, even not cervical or anything. The patient's complaint is, I am having the spondylosis. So you have to find out. And it is sometime they have with the both. Even the last week I have performed for both. Sometimes they have the cervical radiculopathy with the shoulder problem. So, and it is really confusing. So let's see how I can make you clear how to diagnose and how to assess the patient of the any cervical pain or neck pain so that we can make a good diagnosis and manage it. So I welcome you all for 41st ISSP Con. It is most awaited our own national pain conference, which we are organizing in Kolkata, City of Joy. And it is a very good, beautiful venue, Taj Talkuti, lot of greenery, and you will really enjoy it. And I'll promise you will have the very, very fantastic academic program. Don't miss out. Please register yourself. I know IAPM fellows can be registered by the ISSP, but for others, please register. It is early bird is going on. And I promise you, it will be one of the best conference happen in India. Thank you so much. So today's lecture, I'll cover definition, classification, causes, diagnosis by the history, examination, investigation. Because in clinical practice, don't forget to diagnose patient. Listen the patient. 50% of diagnosis you can make by listening the patient, then other by examination. Investigation, really, it is not so important in neck pain. Sometimes it is required if it is so. Differential diagnosis and treatment. Treatment again is a most of the neck pain is the myofascial pain, and it is a conservative. You really need anything to intervene, like intervention or surgery. And I have seen people have the many complication of the surgery. So be careful and make a good diagnosis. So by definition, cervical pain. So neck pain or cervical pain. So it is pain which is mainly in the neck area. It is bounded superiorly by the nuchal line, laterally by the lateral margin of the neck, and inferiorly by the T1. So neck pain is very, very common after back pain. And in fact, at this presenting area, everyone is on the mobile. People have forget other than mobile. They are always on the social media or mobile. So nowadays, neck pain, in fact, I will say it is more common than the back pain. Every patient, young to elderly, is coming with the neck pain. Represent with the fourth leading cause of the disability in United States. Maybe I will say it is now the first cause of the disability. Women are always more affected than men in any chronic pain. Highest prevalence in middle age, even early age. Even I'm seeing the kids are coming because of this text and the mobile phone. 2/3 of people will experience neck pain in their any time of their life, and half of the 3/4 of these people having a recurrence in the 5 years. Incidence, if you will talk about the incidence, the annual prevalence rate is 30%. Cervical facet joint pain is the primary source of the pain. And like in any spinal pain, the facet joint are most common. 54 to 60% of the facet neck pain are because of the whiplash injury. Lifetime prevalence is the 40 to 70%. In a national survey in the US, 5.9% respondent had the neck pain for the most days for at least 1 month. A Finnish survey found a lifetime prevalence of 71% with 13.5% of women and 9.5% of men having the neck pain more than 3 months. Up to 20 to 40% acute neck pain will become chronic pain, but it is very less. Classification again based on the duration. For any pain, it is acute up to 6 weeks, subacute 6 to 3 months, and more than 3 months is always chronic. Pathophysiological, nociceptive, and neuropathic or mixed. Clinical classification, non-neuropathic, only musculoskeletal pain, intervertebral disc, facetal pain, atlantoaxial or atlanto-occipital joint pain, neuropathic pain, radiculopathy, myelopathy, mixed, post-laminectomy pain or Fehlbach syndrome or disc degeneration. If you grade the pain in the 4 category, like grade 1, no sign of major pathology or little intervention, mainly musculoskeletal if you don't find any pathology. Grade 2, no sign of major pathology but may impact daily activity. Grade 3, neck pain with the neurological symptom or radiculopathy. And grade 4 is the major pathology like fracture, myelopathy, cancer, neoplasm or infection. What are the risk factors for the chronic neck pain? Non-modified risk factor like age, gender, genetics. Modifiable risk factor like smoking, lack of physical activity, repeated use of the mobile and text, poor posture because of text, anxiety and depression. Other risk factors, previous musculoskeletal pain, high quantitative job demand, low social support at work, job insecurity, poor job satisfaction, ongoing litigation, poor computer, like any other risk factors which can cause any chronic pain. These are the factors. Common causes of the neck pain, myofascial, acute whiplash, cervical disc degeneration, cervical facet, and loss of the normal slightly lordotic alignment or cervical spine, or what is in layman causes the spondylosis. Radiculopathy, common causes, disc herniation, foraminal or lateral recess compression or stenosis. Non-compressive, diabetes, herpes zoster, Lyme disease, trauma, malignant infiltration, or demyelinating disorder like multiple sclerosis. Myelopathy, spinal cord involvement. When there is a spinal cord involvement, then it is a myelopathy. Causes central vertebral canal stenosis, ossification of posterior longitudinal ligament, causing again in canal stenosis. Large central disc herniation again causes canal stenosis, tumor, infection, epidural bleeding, syringomyelia, and other mass lesion. Cervical spondylosis is actually, if you anyone asks you, give I am having the spondylosis, it is word which define the progressive age-related degenerative changes. So it is not any disease, it is just when the patient is having the degenerative changes because of age, then it is a cervical spondylosis. And it may affect vertebrae, intervertebral disc, or all the ligament and connective tissue. Sometimes the degenerative disc disease may be with the radiculopathy or myelopathy. Pain secondary to other potential underlying cause, infection, any infection like osteomyelitis, paraspinal abscess, retropharyngeal abscess, meningitis, spondylodiscitis, herpes, neoplastic, any metabolism, primary or secondary, or lymphoma, spinal cord tumor, primary bone disorder like osteoid or fractures, generalized pain syndrome, fibromyalgia, or any other myofascial pain, endocrine, osteoporotic fracture, or Paget disease. So pain secondary to any potential serious underlying causes like neurological, any neuropathic, peripheral neuropathy, amyotrophic lateral sclerosis, transverse myelitis, Guillain-Barré, brachial plexus lesion, tension headache, and Shari malformation. Any rheumatologic, most important ankylosing spondylitis, rheumatoid arthritis, or maybe seronegative spondyloarthropathy. Referred pain may be like cardiovascular. So don't forget any cardiological cause or the vertebral or carotid dissection, AV malformation, esophagitis is also sometime cause. And in fact, general public will say, I have the gas, which is causing my neck pain, pulmonary disease, or shoulder. Shoulder is more common for the neck pain because if a patient is having rotator cuff pathology or adhesive capsulitis, it can cause neck pain. Don't forget to rule out any red flag, unexpected loss of weight, history of cancer, unremittent night pain, night sweat, pain worst at rest, neurological symptom, tearing sensation, fever, chills, infection, significant neck trauma, don't forget. And there are conditions which can be cause of the red flag like cervical cord compression, myelopathy, arterial dissection, infection, or any fracture or ischemic heart disease. But we always mention the red flag, but we forget the yellow flag, which are again a very, very big cause of maybe patient is not relieving symptom or patient is having more symptom. And what the New Zealand guidelines group says, the patient has the belief that activity or pain may be harmful, stickness, sickening behavior, social withdrawal, emotional problem, work problem, low or negative mood emotions, unrealistic expectation of treatment, compensation. In railway where I work, people come, so they want to have a leave or anything else. So these are also a very yellow flag. So don't forget it. Evaluation and assessment of a patient. When we evaluate the patient, don't forget the anatomy and anatomy because we have the 7 cervical vertebra, then we have the atlantoaxial, atlanto-occipital joint, which can cause the pain. Even the occipital neuralgia can cause. So we have the different muscles like obliquus capitis superior, rectus capitis. So don't forget the anatomy. I'm not going in detail. And with the fluoro, because most of the time we use the fluoro, of course, we use the ultrasound also. So you should have the fluoroscopic anatomical knowledge also. So because it is different from the lumbar. So we have, if you see, this is the cervical vertebra, we have the 7 vertebrae, and this is the spinous process. This is the body, and this is the transverse process. So in lateral, if you see, this is the body, and this is the and this is the spine. So spinous process, and this is. So when you want to do the any epidural, so it goes here, not the here. So always remember the anatomy. Evaluation as 50% of the diagnosis, you can make very good history. And slowly we forget about the good history, but it gives lot of information. Take a patient and it build up the patient and doctor relationship also, patient's confidence also. Make a good examination, and we really need hardly any investigation. History asks the right question about the pain location, where the pain is, pain quality like dull, sharp, burning, pain pattern, diffuse or discrete, numbness is there or not. If the numbness is there, where the numbness, what the pattern, deficit, pattern, distribution, and not so like onset, incident, event, pain provocation, pain diminish, and what the treatment. You don't forget about the stumbling gait because it make the indication of the other diagnosis, dropping things, hand falling asleep, skin feels burned, trouble going upstairs, urinary hesitation, no pain, no pain, workup and weakness slowly getting worse. Past medical history, no neck disorder, including osteoporosis, osteoarthritis, disc or disorders, risk factors for aneurysm, risk factor for infection, psychological history. If you see the patient of any neck pain, the diagnosis by the clinical presentation, so you don't forget a dermatome. which have the dermatome origin. So we can find out the cause of the pain, like C1 to T5, the sclerotome and myotome are similar. Pain arising from the structure deep to the deep fascia like myotome or secretome. So if you see the referred pain from the facet joint, this is C to C3 area. Here comes C3, 4, C4, 5. So any scapular pain, you can maybe confused with the any shoulder pain or the upper back, but this is the C6, C7 facet. Likewise, C5, C6. So you don't forget the have the this facet joint has the dermatome presentation. And cervical root dermatome presentation, if you'll see the cervical root presentation, then C3 and C4 and C5, it is the upper arm. And of course, T2 is the inside, T1 is the medial side of the hand, and C8 is the, again ulnar or medial side, C7 is the middle two finger, and here comes the C6, where the thumb is. So don't forget all this supply, making the good diagnosis. Why the atlanto-occipital and atlantoaxial and upper cervical joint pain present as the headache or the this? Because spinal nucleus of the trigeminal nerve extend dorsally, caudally to the dorsal horn of the first 3-4 cervical spinal nerves. So the trigeminal nerve and the upper 3 cervical nerves, which provide the afferent fibers to trigemino-cervical nucleus, it is causing the cause of this pain is that. So general aspect of the pain, neuropathic pain, radiating or non-radiating pain, radiating to occipit suggests C1 to C3, pain originating from mid-leg C5, 6, 7, extend to upper arm, and pain radiating down one of the both upper extremities, single or multidermal lower cervical pathology, and the middle finger, index finger, and thumb are most commonly involved because of C6, C7 are most commonly affected. History, aggravating, elevating factor like mechanical, non-inflammatory musculoskeletal pain is always worse with the movement, and it gives rest, gives the relief. Myofascial pain and pain related to muscle strain are worse with the head turn away from the symptomatic side. If the patient has the left side pain, if you patient see the right, the pain because of the muscle strain. Discogenic pain again worse with the forward neck bending, and radiculopathy, facet pain often worse with the extension of the neck. Aggravating and elevating factor like radicular symptoms are often lessened by abducting the shoulder and placing the hand behind the head. It causes the less pressure in the spine. Radiculopathy pain secondary to herniated disc may worse with the cuffing, valsalva, which can cause the increase in the intraspinal pressure. Morning stiffness is mostly is the ankylosing spondylitis or rheumatological origin. Arm pain worse with the neck extension causes the spinal stenosis. Clinical presentation of history, neuropathic neck pain, isolated shoulder may not involve neck. So sometimes neuropathic neck pain may be only to the shoulder, and again you are confused whether it is a cervical pain or shoulder. Pathology, pain may be exacerbated neck extension, rotation, relieved by abduction of the shoulder, deep diffusing aching pain, stiffness in the proximal structure, and numbness, paresthesia, dysesthesia with the neuropathic pain. Dermatomal and myotomal boundaries are often imperfect and may be overlapping. Radiating symptom may be sometimes totally absent. With the disc herniation, what are the specific characteristic? Onset again acute and unilateral. If it is acute disc prolapse, and symptoms worsen with the increase in the intraspinal pressure like valsalva, coughing, sneezing, positioning, prolonged sitting, standing, or bending. And central spinal canal or foraminal stenosis, the pain is usually indolent, more indolent, distribution often bilateral because it's a central canal stenosis, asymmetrical in severity, multi-level neuropathic symptom, worsen with the walking, prolonged standing and neck extension, and always relieved by the neck flexion. Cervical myelopathy, what are the characteristics? Onset is gradual and insidious. Waxing waning symptoms may present in number of ways like clumsiness, paresthesia, abnormal gait, pain and stiffness, occipital headache sometime, hand clumsiness, decreased fine motor skills, balance problem, and bowel and bladder symptoms. Sometime it is there, and always look for it if the myelopathy. And you can doubt if the patient is having bladder, bowel, and sexual dysfunction. You can always doubt about the myelopathy. Physical examination, you see gait, higher function, inspection, palpation, range of movement, sensory motor examination, reflexes, spatial test, and other system examination. In inspection, neck, you should inspect for any deformity, arrhythmia, rash, scare, or acute infection, swelling, muscle wasting, facial characters like head position, involuntary movement, deformity, patient's eyes. Always don't forget about the eye examination in stigmas or people abnormality of the cranial nerves. Palpation, you should always palpate the neck, paravertebral muscles, shoulder, my local tenderness, taut bands, any myofascial trigger points. Then always see for the all the bony landmark also. Now the neck movement, the active range of movement, extension 0 to 50, lateral flexion 0 to 45 is normal, rotation 0 to 80, patient can do 80-degree, flexion again 0 to 80-degree, and all the combined movement 0 to 130. And passive movements, if active movements are limited, you can check for the passive movements and resistance, registered range of movement. Sensory, so there is as the sensory supply, we have seen the dermatome, so always check for C1, C2, C3, occiput and upper back. C4, lower portion of back, neck and superior aspect of shoulder. C5, deltoid and infra and supraspinatus. C6, deep dorsal forearm, thumb, index finger. So it is a radial. C7, triceps, index, middle finger and wrist extension. You can see the for this median nerve also. C8, fourth and fifth finger, and the ulnar side, T1, underarm and finger extension. You can grade the muscle functioning also like 0, total paralysis, no action, 1, palpable or some contraction, 2, active movement, full range of movement with the gravity eliminated, 3, active movement, full range of movement with gravity, against the gravity, 5, active movement, full range of movement with against the gravity and moderate resistance, and 5 is the normal. So you always check the muscle function and note down. If you don't test, then not testable. Shoulder elevation, C3 and C4, you can ask the patient to lift your shoulder up and hold. Do not let me push down. Shoulder abductors are C5. You can check. Elbow flexion is the C6. Always check the elbow flexion. And elbow extension is the C7. Thumb C8. And finger abductors are T1. So you can always ask the patient to do all this movement and check all the nerve root. Reflexes, very important to check. Biceps C5, C6, triceps C6, 7, 8, and brachioradialis is the C5, C6. So inverted radial reflex is the brachioradialis reflex. Is the positive response is wrist and finger flexion. Negative is the wrist dorsiflexion. Positive in the cervical myelopathy. Vertebrobacillary insufficiency, there are many tests with which you can detect the vertebrobacillar insufficiency, like Horton test. Here the vertebral bacillary arteries, as they pass through the neck, there can be a vertebrobacillary artery compression. So patient can have dizziness, tremor, rigidity, sometime blood vision, numbness, tingling, sweating, flushing. So Spangling test is very, very important, where you can check with the foraminal compression test, nerve root pain and the facetal pain, head in extension and rotation to the unaffected side. Gently apply the pressure, patient will have the pain. Compression test again for the C. Spine nerve root compression and disc pain. Head in neutral position. Gently apply the pressure. Patient will have the pain. Distraction test. Radicular symptom and ligament sprain. One hand under the patient chin and the other under the occiput, and gently apply the traction directly away from the spine, above. Test is positive, symptom decreases because you are decreasing the compression. Finger escape sign indicating cervical myelopathy. Again, ask the patient to hold his or finger in extension. If the patient has the myelopathy, the fourth and fifth and sometimes middle finger, they flex and abduct itself. Shoulder depression test for the brachial plexus injury and Bacodi maneuver shoulder abduction pain relief. It position of the affected arm or head through the abduction of the shoulder. Positive release, relief of ipsilateral pain such as cervical radiculopathy with the 90% specificity. This test give you 90% specificity and sensitivity of the 50%. Negative result, pain that remain the same or worsen such as the shoulder pathology. So it is very important this test, Bacodid maneuver, because as I said, sometimes patient come with the shoulder pathology and cervical pathology mix or sometimes very confusing. Upper limb tension test or the LV test for the brachial plexus tension test. It is a comparable to as we do SLR like that. Patient supine position, depress the scapula with one hand while abducting shoulder to 90° with the elbow. Flexion is the 90° of flexion. Supinate the forearm and wrist, then extend the wrist and finger. Push forward on hand to laterally rotate the shoulder. Extend the elbow. If the patient is having pain, then test is positive. In the central spinal canal compression, compromise, patient can have the muscle weakness, upper motor neuron lesioning findings like hyperreflexia, increased tone may be noted below level of the spinal cord level. Most common myotome is the C5, C7, ataxia or diminished fine motor movement, sustained ankle clonus in the upper motor neuron lesion, more than 3 bits of clonus, and sensitivity is the 50%. So we must always check if the patient is coming with a cervical pain also, then also you always check for the ankle reflexes, because maybe Babinski sign is in upper motor neuron lesion and Hoffman sign is the upper motor neuron lesion may be present in normal people also. So positive when there is a quick movement of the thumb into flexion and adduction elicited by flicking the nail of the patient's long finger. The other how I have divided in how we can diagnose the condition with the symptoms and physical examination. So non-neuropathic pain like mechanical, musculoskeletal and axial pain, if it is a myofascial chronic pain, like anywhere in the neck or shoulder region, trigger point, paraspinal tenderness, local twitch response, and referred pain sometime. Clinical diagnosis is important. Cervical strain or interligament pain, then axial pain, pain and stiffness again, midline tenderness, muscle guarding, no neurological deficit, and clinical diagnosis again. If patient is having zygophysial or facetal pain, bilateral or unilateral, again if pain is in the neck with the no neurological symptom, patient may have the pain in occipital, temporoparietal or upper back or shoulder area also. Range of movement of neck is reduced, paraspinal tenderness may present, no neurological deficit. And we can diagnose it with a diagnostic biopsy like a cervical medial branch biopsy or the facetal injection. Non-neuropathic pain, musculoskeletal again, cervical discogenic pain. It may be axial neck pain, shoulder, non-radicular, headache, ocular, many type of the symptom present if the patient is having discogenic pain. But the pain increases with the cuffing, lifting neck flexion and reduced neck range of movement may present. Patient's pain increases in the flexion, poorly localized sometime. So careful diagnosis and clinical correlation, and if needed, then only imaging is required. Whiplash, if patient has any history of the whiplash, then check for the neck pain, neck stiffness, occipital headache, dizziness, sometime present. They will give the history ki I had the accident and after that I always feeling the dizziness. Pain may refer to trapezius, shoulder, mid back and face. There is a paraspinal tenderness, reduced range of movement, weakness of upper extremity may because of the pain. It may be present. Clinical diagnosis and sometime diagnostic MIPS is important. Again, cervical spondylosis, degenerative spinal disease, weakening in the morning with a stiff and painful neck. It may present in the ankylosing, don't forget it. Diminished range of movement and direct, the diagnosis is difficult, but sometime because of age and other symptom, you can make diagnosis. For neuropathic pain, cervical radiculopathy, the radicular pain may be present, maybe weakness is present, neurogenic claudication, sometime there is a disc herniation, sometime, and the patient symptom improve with the supine position where increase with the flexion. So diagnosis, diminished deep tendon reflex, mild decrease in upper extremity strength, positive provocative tests like Spangling test, shoulder abduction, neck distraction, and upper limb tension test is positive. Diagnosis is always clinical, and if needed, MRI may help you in the diagnosis. Cervical spondylotic myelopathy, again, it is a central spinal canal stenosis because most of the degenerative disc disease and facet arthropathy and ligamentum flammum hypertrophy. Check for the always claudication, neurogenic claudication, stiffness, neck pain, paresthesia, arm weakness, gait deficit, radicular symptoms, sphincter function, bowel and bladder, sexual dysfunction. Diagnosis, we can check sensory motor test and there is other test, Hoffman test, Lermit sign, upper motor neuron sign. Always check for it. MRI, CT is the confirmatory of diagnosis. So diagnostics procedures, what is the help in? Evaluation of neck pain, investigations are hardly required. Don't jump when the patient come with acute neck pain, never go for any X-ray or any imaging. It is not required. But if required, plain X-ray in flexion extension, CT, MRI, these are diagnosed, EMG, and the blood tests and blood tests. So always avoid the blind diagnostic test because if you do blind diagnostics and there is a accidental finding of the any small disc and you are going for any MIPSI or any intervention and patient can cause the complication. So it is very, very important when to give imaging or when not to do the imaging. X-ray is really very, very less helpful in cervical spine, but sometimes for the patient satisfaction, you have to do, but it is really not required. And if required, then always do patients AP and lateral, and mostly it causes if the patient is having any fracture or any other major problem, then you can check. MRI and CT are the most, MRI is the gold standard always for the cervical radicular pain or spondylosis or the myelopathy. So always check when anything you want to do is the MRI. Indications for MRI, any focal neurological deficit, progressive neurological finding, persistent pain, more than 6 weeks, pain refractory to conservative treatment, concern for the myelopathy. If you find any symptoms, sign of the myelopathy, if you expect any fracture or any trauma history, pre-surgical or pre-procedure evaluation, if you want to do any procedure, history of cancer or presence of red flag signs, and degenerative changes, then these are the indication for MRI. CT myelography. CT is better if you suspect any fracture or bony disorder or spinal malalignment, then CT is better than X-ray. CT is preferred over MRI. Patient has any prior history of the trauma or anything, or where the MRI is contraindicated. Functional testing. We can do electrodiagnostic like the EMG or NCV test, and especially EMG and NCV may be alone or maybe combination. So if you find any patient is having poor correlation with the MRI and physical examination, then maybe require the NCV test. or if patient is having cervical radiculopathy, brachial plexopathy, peripheral nerve entrapment like carpal tunnel, because sometimes the carpal tunnel patient also have the same symptom as the radiculopathy, cervical radiculopathy, then you can go for the NCV test to confirm the diagnosis. And always sometime you have to find out the which nerve roots are dysfunction then also. Laboratory investigation is all the routine investigation, only specific test when you are suspecting any rheumatological disease, then you go for the other special test or malignancy, otherwise routine investigation. Diagnostic intervention or diagnostic MIPSI. So if you suspect any facet joint pain or the whiplash injury, then you can go for the fluoroscopy or USG guided. Nowadays, we are shifting mainly to the USG guided medial branch block or the facet intraarticular injections for that. And if patient is having more than 50% of grade pain relief, then you can go for the radiofrequency. DD. The DD in DD most important is the thoracic outlet syndrome. You have to always, very important to find out or identify the thoracic outlet syndrome. So if the patient is having cause is neurogenic is up to 95% of the patient, and remainder is the vascular in origin. So it is common to find coldness, patient is having coldness, paleness of the limb. Paleness is more common in the upper limb, skin changes in the distal limb, neck pain may or may not. The Edson maneuver or the Ross test is positive. You do this test if you suspect any thoracic outlet syndrome. The plain radiograph may note any cervical rib or elevated transverse process of seventh vertebra. Ultrasound, sonography, and the vascular imaging like MRI, CT can assess for the underlying cause like any tumor. Diagnosis of exclusion is typically neurogenic thoracic outlet syndrome. Diagnosis may be aided by the electrophysiological examination. Temporary symptom relief may be by injecting local anesthetic into the anterior scalene muscle. Shoulder disorder, as I'm again repeating, the shoulder disorder is more associated with the cervical pain or may present as a cervical pain. So rotator cuff pathology, check for rotator, do all the tests for the rotator cuff pathology. Classical pain is reported in anterolateral shoulder. Overhead movement typically worsen the pain, whereas the cervical pain is relieved by the overhead extension. Ultrasound MRI is useful for diagnosis. Carpal tunnel again is one of the disease which is again confusing with the cervical symptom. Patient can complain she is having numbness of the finger with the radiating pain upwards to whole upper limb and sometimes neck pain. So this is a very common and usual patient present with this symptom. So carpal tunnel syndrome is always happening because of the compression of the medial nerve in the carpal, because of the sometime overuse of the hand or prolonged improper position, more common with the female. And patient may have the loss of fine motor movements, cannot hold the things properly. Sensory abnormality may present, weakness or pinch or grip strength, and NCV is always confirmatory. Brachial plexopathy again is very coinciding with the cervical pain, like injury, strain, or inflammation. Can present the similar cervical radiculopathic pain, paresthesia, most occur in the autoimmune inflammatory process like brachial neuritis in patient. So if you check and you diagnose, then give the treatment. NCV and MRI is always confirmatory. Multiple sclerosis, again, patient come with the other symptom and the neck pain also, and it can cause the gait disturbance, but you can always find out doubt the multiple sclerosis because there is the muscular weakness, sensory defect, gait disturbance. Then there is a autonomic sites like central nervous system. Patient can have trigeminal pain also. Patient can have optic neuritis also. MRI is always confirmatory. Amyotrophic lateral sclerosis, again, it is a progressive degenerative neuromuscular disease affecting upper and lower motor neuron. And similar to myelopathy, radiculopathy symptom is present, insidious onset of progressive weakness of upper and lower Motor neuron, some distinguishing clinical feature may be ALS, primary pure motor syndrome, sensory may intact or may affected. Motor neuron deficits are diffuse. So if you have any doubt, then go for the MRI again. Others are like transverse myelitis, spinal epidural abscesses, or neoplasm. Now we'll go for the treatment. Treatment again, most important, as the 90% of the pain are musculoskeletal pain in neck pain, and it can be treated conservatively, efficiently. So it is very, very important to reassure the patient. It is a very temporary, you will get the good relief, educate the patient about the normal course, avoidance of the exacerbation factors, select the stretching and strengthening intervention, judicial use of the pharmacotherapy, home in-home exercise program, and with the rehab, patient can be all right. If required, then pharmacotherapy, muscle relaxant. Sometime in muscle pain, there is a lot of muscle spasm present. So you need a pharmacotherapy in the muscle relaxant, like cyclobenzapine is more very effective. The other astatizandine, baclofen, chlorhexidine, metaxone, or thiocalcicoid. These are the muscle relaxant. If you give for short time, like 8 to 10 days, patient have the good pain relief. In analgesic, NSAIDs are the first line of drug in the acute pain. However, no high quality evidence support the NSAID treatment. But if the patient come with the acute musculoskeletal pain with the neck pain, you can give the NSAID with the muscle relaxant. And sometimes NSAID gel also is very, very effective. Lidocaine patch, if patient is having neuropathic pain, localized use of the 5% lidocaine patch. Opioid analgesic, like short-term use of the tramadol, but no long-term of use of the opioids are indicated. So you should be very aware of it. Maybe second line alternative, like NSAID for severe pain, you can give like in ankylosing spondylitis and other type of the rheumatological problem. So drug monitoring program, and you should always see what the patient is on. Corticosteroid, normally corticosteroid are not indicated, but if patient has the acute disc prolapse and the acute radiculopathy, then sometimes short use of the corticosteroid can be given for the radiculopathy. So normally it is the 8 to 10 days of the treatment. Start with the dose. You can start with the 5 to 60 milligram of the single or divided doses, and the patient is having good relief, then after 5 to 7 days, you always taper off. Anticonvulsant, always gabapentin and pregabalin or tricyclic antidepressant and other anticonvulsant or other centrally acting medications. Start with the very low doses and then you can increase. But don't make the patient depend on them and use, if most patients are very, very elderly, so start with the very small doses. Surgery, indications of the surgery for the cervical pain is very, very limited. And if you have to confirm the diagnosis and confirm the indication for surgery, then only you can refer the patient for surgery. The surgical decompression or fusion surgery may be the multiple disc or the huge disc prolapse with the myelopathy or radiculopathy or the compression, cord compression. Then it required the course surgery. Radiculopathy with deficit surgery maybe, or maybe the MIPSI you can help. Myofascial pain, no surgery. Peripheral nerve entrapment. Normally it is very good if we give the ultrasound guided interventions, but sometime it requires the release. And double crush syndrome, it depends. So intervention or our intervention pain management or the MIPSIs, which are, if you sometime for the diagnosis and the therapeutic use of the medial nerve, cervical medial nerve block with the ultrasound guided or the fluoro guided, you can do both way. And first do the diagnostic intervention. If the patient is getting more than 50% relief, then go for the radio frequency. So here you can see how we are going here. There is required, there is ontoid where we give the needle under fluoroscopy. And then you can give the 0.2% of the ropivacaine or the sometime 0.25% of the bupivacaine. It require only 2 ml of the drug. For persistent discogenic pain, interlaminar epidural also important to do, and you can always do. American Society of Intervention Pain Physician guideline offer a moderate to strong recommendation for the cervical epidurals in the management of the chronic neck pain due to the axial discogenic pain, facetal pathology, disc herniation, which respond very adequately. So here you can do the oblique position first in AP, give the needle 1 or 2 level down and start doing. And in oblique, confirm the needle position in the fluoroscope and you can see the dye spread. Always remember to give the dexamethasone because avoid particulate steroid. It may cause the embolism and then patient can go for the neurological complication. So start always use the dexamethasone or no steroid. Sometimes myofascial musculoskeletal neck pain, the dry needling or the is very helpful, or sometimes Botox injection or trigger point injection. These are very helpful. You can always do the ultrasound guided dry needling. For radiculopathy, if patient is having standard treatment for acute cervical radiculopathy like physical therapy or the home exercise program or physical therapy, avoidance of the strenuous activity, reassurance. Some data also suggests the multimodal interdisciplinary management like the with the medical management with the adjuvant like nortriptyline, gabapentin, pregabalin, duloxetine, or maybe epidural steroid injection. A moderate to strong recommendation for fluoroscopic guided cervical interlaminar epidural is always there. Myelopathy, acute myelopathy is neurosurgical emergency and always refer the patient to the surgeon. Complication and prognosis. Prognosis of general neck pain is the outcome is very good and duration is the best predictor of outcome. So have patience, reassure the patient. Shorter duration is associated with the better prognosis. Greater severity of reported pain and presence of neuropathic pain are associated with the less favorable prognosis. Less severe reported pain and absence of neuropathic pain is always very good prognosis. In acute neck pain is always self-limiting, spontaneous resolution is always there, maybe 1 or 2 weeks or 3 to 4 weeks. Pain recurs or persists in about half of the patient beyond 1 year after the initial episode, then specific investigation and treatment is required. Factor associated with the poor prognosis, female sex, old age, comorbidities, psychosocial pathology. So always look for the what are the factors if the patient is not improving conservatively. Whiplash, up to half of the patient report continuous pain after 1 year, so they need the treatment. Cervical radiculopathy, again, is spontaneous resolution occurs 76% of the herniated disc. Improvement is expected in most of the patient by 6 months. About 90% of the patient treated non-operatively experience mild or no pain at the long-term follow-up, like 5 years follow-up, and it include both conservative and intervention. So most of the patient after 5 years are the same, whether you do something or not. Sometime recurrence rate after non-operated may occur in about 1/3 of the patient, but you can again repeat the intervention pain management. Cervical myelopathy, natural course of mild to moderate myelopathy is variable when not treated surgically. Results from a small randomized prospective trial suggest that long-term outcome amongst the patient with managed without surgery compared with the patient managed surgically may be similar for mild to moderate disease. So always twice check for any undergoing any surgery. Decompress surgery is effective for patient where the severe disease is present. So these are the references. So again, I'm inviting you all for 41st annual conference of ISSPCon. Thank you so much.
Thank you, Krishna. It was a very elaborate and wonderfully covered by you. Each and every aspect of neck pain was covered, starting from the definition up to management and prognosis. So
Yeah, huge topic.
it's a huge,
I
really
tried to
huge topic.
cover.
It is really very difficult to cover it. You can go on speaking.
Yes,
For
yes,
this,
yes.
there should be two parts, I feel, of neck pain, part one and part two.
Yeah,
So it
better
will become
because
easy. Because
I,
management and its prognosis complications, it's better if we cover in second. And
yes.
in first, all the diagnostic tests and everything.
Yeah, because we can give this suggestion.
Suggestion, we will
Right.
definitely try
Yeah.
to give.
It's a
Because
huge topic, huh?
so, if anyone
Any
has
question?
any questions, you can put in chat box, which will be covered. Dr.
Yeah.
Manjari is there, Dr. Kashinath is there. So, you all can come up with your queries if you have. Otherwise, I think so each and every point is properly and excellently elaborately covered by Dr. Krishna. Are there any questions, Manjari, in the chat box?
No, ma'am. No
No.
questions.
Okay.
Okay.
So all have understood, I think so.
Everyone is tired.
Ma'am,
They
it
all
was
have
a
understood.
very elaborative lecture.
Yes.
It's a very
Huge topic.
huge.
Thank
Thank
you
you.
so much. Thank you so much, Dr. Krishna.
Thank you, Dr.
Manjari,
Saj.
if there are no
Yes, ma'am.
questions, shall we conclude?
Yes, ma'am. As you
Uh,
wish. We can
okay.
conclude. Yeah.
Yeah.
Thank you, ma'am.
Thank you.
Thank you, both of you. Thanks a lot.
Yeah.
Thank you
Thank
so much.
Good
Good
night.
night. Good night.
चिल्लाओ नहीं मैं इसमें हूँ अरे तो ठीक है ना अरे मैं इसमें वहां आ ही नहीं रहा था अचानक यहाँ आना पड़ा अचानक यहाँ आना पड़ा मुझे वहां पे आ ही नहीं रहा था तो मैं क्या करते
तो एसी खोल के गेट खोल करके रहा